So, thank you very much indeed for the opportunity to address this subject. Drink, eat, move after major surgery. Enhanced recovery is helping our patients live the dream. I'm a professor of anaesthesia and critical care from University College London in the United Kingdom. And in the past, I was a national clinical lead for the widespread and adoption of enhanced surgical recovery principles in the UK National Health Service, working for our government. Those of you who've been to this meeting before, the first section of this talk will be a recap of that. But at the back end, I'm going to show you some new data that is in press at the moment, which I think reinforces the idea that enhanced recovery is helping our patients live the dream. I've got a number of potential conflicts of interest, as shown here, including being a director of evidence-based perioperative medicine, that's celebrating 25 years this year, and being the founding editor-in-chief of the free open-source medical education podcast, Top Med Talk. So please do go and listen to that. It's all free. So I'm just going to touch on this to set the scene. This is an excellent publication, in my opinion, from Johns Hopkins, published in 2016, so 6 years old now, looking at bundled payments for surgical colectomy after Medicare enrollees, the potential savings versus the need for reform. We concentrate here on the right-hand column, so it's 821 patients undergoing elective colorectal surgery in Johns Hopkins. And you can see the post-operative morbidity rate is 28%, so bear that number in mind when we look at the data at the back end of this presentation. And the length of stay, reported as median and interquartile range, is 8 days, with an interquartile range of 5 to 14. So 25% going home within 5 days, 25% staying more than 2 weeks. But that's not home, because if you look below, you'll see that the discharge disposition, 58% are going to home, but 40% are going to an additional care facility. So I think we don't know what the real length of stay to own home is in this, but bear in mind the 8 days with the interquartile range of 5 to 14. The other thing to note is the observed to expected length of stay, being more than 1 day longer than expected, is 51%. So about half the time, the group is saying that they got that expected length of stay wrong, and that has a knock-on effect with regards to patient flows. The real point of the paper is the potential cost implications of complications and the observed to expected length of stay being greater than expected. So in the center here in the brown bars, we're looking at the total cost with and without a complication. So as we know, surgery 2016 was already quite expensive, over $20,000, but that doubled with a complication. That's extremely well described in the literature. We know that. It's the complications that take all the money and cause all the misery. They also have a big impact on length of stay, and you can see that the observed to expected length of stay being 1 day longer, so an extra day more than predicted, more than doubled the cost of care. So 2 big things we're looking to do to get down that length of stay and reduce complications. This is from an editorial that I published with Professor Henrik Kellett around the time that I was a national clinical lead for enhanced recovery in the UK. Professor Kellett is accredited with basically inventing enhanced recovery. We'll go over that in a little bit more detail in a moment. He's a surgeon from Copenhagen in Denmark. This sort of editorial was about why is the surgical high-risk patient still at risk. But within the editorial, we refer to the historical data in Europe immediately prior to our national efforts to adopt enhanced recovery, where the length of stay in the UK and across Europe was a mean, not median, of about 10 to 12 days. And Professor Henrik Kellett was telling us for a long time that he could get patients home in 2 days. Okay, that's fine. We'd say, well, that's because you're from Denmark and everyone's very healthy. It's not like that in the UK. He said, no. This big gap between the two is almost entirely explained by iatrogenic harm caused by traditional care packages and variation in practice, and is almost completely avoidable. So that was traditional care compared to enhanced surgical recovery. Now, it's 25 years since Professor Kellett and colleagues first published the idea of enhanced recovery, called Fast Track at the time. Here's 2 of his earliest publications. Notice the first one is about a multimodal approach to control postoperative pathophysiology and rehabilitation. And it's published in the British Journal of Anaesthesia. So a Danish surgeon publishing in the British Journal of Anaesthesia mainly about multimodal pain management. For quite a long time, many of us thought Professor Kellett was actually an anaesthetist. He actually was given a sort of a prize of merit by the ASA for his contributions to multimodal analgesia. The next one we see is a review article in the British Medical Journal by two surgeons, one from the USA, from the Boston area, I think, Doug Wilmore, with Henrik Kellett from Denmark. So two surgeons writing in the British Medical Journal about recovery from surgery. And you ask them why, and he says, well, it was actually quite hard at the time to get this published in surgical journals because we were really challenging the status quo. In the article, they say, well, we know what delays recovery from surgery. It's pain, stress, nausea, vomiting, hypoxemia, sleep disturbance, fatigue, immobilization, drain strips, tubes, etc., etc. They proposed within the journal a new way of doing things. The first major thing they said was that the staff should be trained and reorganized for procedure-specific care plans. So we had two surgeons saying, stop having surgeon-specific care plans. So it's not Professor Kellett's bundle of care, it's the patient's bundle of care. And because they're having this procedure, it should be a procedure-specific care plan. And then they said there are only four major items that we need to deal with: preoperative information and optimization of organ function, stress reduction, effective pain relief and prophylaxis for nausea and vomiting, and then modification of the perioperative care to achieve early mobilization, minimal use of tubes, drains and catheters, and oral nutrition. So the objective was to get the patients drinking, eating and moving within 24 hours. And they called that at the time fast-track surgery, which went on to be known, because that sounded as though people were rushing things, to be known as enhanced recovery after surgery, or ERAS. The other thing that Professor Kellett and the others said at the time was you must have data. You must document morbidity, safety, cost, and patient satisfaction, because you want to achieve the quadruple aim. Now, one of the immediate reactions was, well, you can only really do this fast-track thing for young ASA 2 and 3 patients. And very soon after those publications from Henrik Kellett and Doug Wilmore, we saw the group in Cleveland in the USA, led by Connor Delaney and Tony Senegor, publish on fast-track postoperative management protocol for patients with high comorbidity, undergoing complex abdominal and pelvic colorectal surgery. So the highest risk patients were actually getting the greatest benefit. Well, what about the UK story? Well, in 2009, we, along with much of the world, experienced a global financial crisis. We had basically, because we have a national health service in the United Kingdom, we had to face up to the reality that because the country was broke, it meant the health service was broke. As a result of that, us leaders in healthcare were taken into darkened rooms and told that no matter who was elected to run the country, there would be a budget freeze on healthcare expenditure that would probably last from then on. And that's turned out to be true. Effectively, a 20% cost pressure in a 5-year period meant that in real terms, if you were holding $1 today in 5 years' time for healthcare spend, you'd be holding 80 cents. At the same time, the politicians told the public that they would deliver increased quality for less cost. Now, one of the areas they went after was elective major surgery. So myself and Alan Horgan, so me as an anaesthetist and critical care physician, and Alan Horgan, a colorectal surgeon who was an early adopter of enhanced recovery principles, were appointed by the government directly to work with the health service to try and rapidly accelerate the adoption of enhanced recovery principles throughout the National Health Service in England to start with. It was a data-driven exercise. So here's some information. We were shown many examples of this that the government shared with us around the time that we were appointed. They said, this is the chaos that we're dealing with at the moment. What we have here is a graph of the number of completed elective cases. These are colorectal resections, ICD-10 coded patients, for a roughly 3-month period from 2008, the back end of that, into early 2009. And what we're looking at here is the mean length of stay in days, and you can see that it's highly chaotic. But the really chaotic component is each one of these blue diamonds represents a single hospital or group of hospitals. So 3-month period, cast your eye across at about 50 cases, and you can see that one institution has a mean length of stay for colorectal resections of about 5.5 days, and another one has got one of closer to 18 days. So, how can that possibly be so? It's the same healthcare system. It's broadly speaking the same patients, the same providers, etc., etc. What was dragging that cloud out to the right-hand side? Well, if you ask the hospitals at the extreme edge of the cloud, as you look at it on the right-hand side, why their length of stays was so long, they would use the usual excuses. Our patients are sicker, it's hard around here, everything's more difficult. And we looked into that, and it turned out not to be true. Those explanations did not hold up to scrutiny. They basically had worse results. They had excess morbidity. They had longer lengths of stays. They had all the reasons we referred to in those early slides about cost and getting their predictions of length of stay wrong. What about the other end of the spectrum? So when we went to visit the hospitals in that red box there and said, what are you doing that means that your length of stay is so much shorter than the middle of the cloud or the other end of the cloud? They said, well, it's not difficult. We listened to the enhanced recovery principles. We visited Professor Kellett or Professor Delaney or Dr. Senegal, whatever it was, and we learned to do enhanced surgical recovery. So we, with the government, said, well, this is really easy. We've done our experiment within our healthcare system. We're now going to write to everybody outside of the red box on the right-hand side and say, you've got to try this. So we were allowed to write with government authority to the C-suite of every hospital in the country and say, the government would like you to try these enhanced recovery principles. Oh, and by the way, if after 2 years you haven't tried it, we're not going to send you any more cases to do. If you try it and it didn't work, then we'll work with you to understand why it didn't work. But not trying it just because you're being awkward and you think you know better is not an acceptable excuse. If you haven't tried it, then no more cases. And that got a lot of attention. The people said, well, what is this enhanced recovery thing? So we got those early adopters to write down all of the points that they addressed, and there's about 30 different things on here that goes from a pre-hospital to discharge home. The important thing we emphasized was that they were aims and objectives, not instructions, and we published them on national websites and made it free and open access and no extra money required. Here's the playbook, here's the cookbook, just get on with it. We had very rapid adoption because of that stick and carrot approach from the government that basically says, if you don't try this, and we'll help you to try it, then we're going to take your cases away. That within 6 months, we had 85% of hospitals in the NHS in England trying enhanced recovery in one of 4 major pathways. Here's one of our midterm reports. So this is a progress review from 2012-13 and a level of ambition going forward to 2014 and 15. We said that we would judge the programme according to a reduction in the mean length of stay for all surgeries in the whole healthcare system. We weren't going to just analyse the ones who were very early adopters of enhanced recovery or cherry-picking patients. We said every single patient in the healthcare system will be considered. And we must see a reduction in mean length of stay, not median length of stay, for all comers in the categories of surgery. Colorectal shown elsewhere, this is hip, knee, the gynae procedures and some of the major urological procedures. And indeed, across the whole healthcare system, from 2008-2009, as shown here, to 2012-13, we saw a reduction in the mean length of stay for all procedures in the country. And there, for example, is the primary joint replacements, where we've gone down by 2 days for the whole country. Now, obviously, within that, there are people doing day case hips now, day case knees, but this is every patient in the country. So we're able to demonstrate increased productivity increased quality, increased patient satisfaction, and reduced cost. So we'd achieved the quadruple aim. We were basically the equivalent of opening hospitals for free because of the bed days that we'd freed up, and we released cash within the financial year for money that we weren't spending on avoidable morbidity. This went so well that by the 30th of April 2012, the healthcare leaders in our country, the leaders of anaesthesia, of surgery, the people who run the National Health Service, signed a declaration in public that said we believe that enhanced recovery should now be standard practice. And it's effectively been that since 2012. So if you go to medical school, you only learn about enhanced recovery. If you go to nursing school and so on, you only learn about enhanced recovery. If you go to a surgery exam and you say, I'm going to leave a nasogastric tube in somebody because they've had a segmental bowel resection, because we think that's their benefit, you fail that exam because we know that is wrong. So they don't let you become a surgeon if that's the way you think and the way that you act. As a leader in these sorts of systems, one of the challenges you have in visiting hospitals is to try and distinguish the people talking enhanced recovery from the people walking enhanced recovery. So it's easy to print laminated plans and it's easy to make t-shirts and to put up posters. I can tell you, having visited very, very many centres around the world, hundreds now, and very many centres in the USA, that real enhanced recovery programs, most patients are sitting out of bed having breakfast the following morning. That's what real enhanced recovery looks like. Within 24 hours, the patients are drinking, eating, and mobilising. And myself and colleagues wrote that up in Anaesthesia in 2016 as living the dream. It's no more complicated than that. Get your patients drinking, eating, and mobilising. And then if you're struggling to do that, go back upstream and say what it is that we are doing or not doing that is stopping everybody from drinking, eating, and mobilising. The 4 pillars of enhanced recovery are exactly as stated by Professor Kellett right at the beginning. Preparation. If you can do minimally invasive surgery, that's always going to help, but it's not essential. And then for us, team anaesthesia, it comes down to pain management and fluid management. Reduce the morphine equivalence with a multimodal approach. Use as much regional as possible or practical, although it's not essential. And then get your hemodynamic and fluid management right. Because if you don't have those things right, your patients can't drink, eat, and mobilise early. This slide here denotes after the party is over, the clean-up phase. So we had a great introduction of enhanced recovery. We had very widespread adoption and we saw great national results. We then had to set about trying to understand what was working well and what was working less well. This slide here addresses compliance with the elements of enhanced recovery. So don't worry too much about the detail, but the red says the preoperative bits, the green are the sort of intraoperative bits, and the yellow are the postoperative bits. And the 80% level was the target we set for compliance with the elements of enhanced recovery that we tracked in tens of thousands of patients. And things that people said would be difficult, like the preoperative visit and the carbohydrate drink, we did pretty well with some of them. The carbohydrate drink, for example, turned out to be the hardest thing to do, or just reducing the period of MPO. But if we look at the back end of things, getting people drinking, eating, and moving, which people thought would be really difficult. So letting people drink immediately after colorectal surgery, letting them have food in the recovery area, letting them sit out of bed and having breakfast the following morning, we were hitting 90% rates for the whole program, which was very encouraging. We then went on to do this publication, which was to look in detail at our enhanced recovery program and ask which elements of the enhanced recovery represent the secret sauce. And the bottom line is that there is no secret sauce. Your enhanced recovery must achieve greater than 80% compliance with the pathways to see most improved outcomes. The higher the dose of reliably delivered enhanced recovery, the better the outcomes. We then saw at a national level a little bit of slippage. We had a change of government, we had a change of attitude. We went from being very brave and innovative to going back to being cost-cutting. And we stood back and said, well, we wonder why that happened. And I think what happened is these 8 Cotter steps is we delivered 1 to 6 very successfully, which was increasing urgency, build the team, get the vision right. We'd communicated for buy-in, we'd empowered action, and we generated short-term wins. After the short-term wins, the government decided to cost cut and said, well, we don't need these teams anymore. Everything will be fine. We fixed that problem. Not true. So we let up and we didn't make it stick. So in my own institution, we saw things drift back close to the way they were before. The passive-aggressive individuals who didn't like enhanced recovery become very effective once you take your foot off the gas, once you let them get back out there and start to disrupt. So we received a government grant to develop a very simple application. You can't buy this, it's not a commercial product. Please don't hesitate to make your own. Where we recorded drink, eat, and move as something that was very tangible. We put it on this app, and we could publish the results and share them on a regular basis. One of the great things the teams did is that they actually used the patients to populate the drink, eat, move. It's very boring being in hospital. It's even more boring if you're on an enhanced recovery program, because basically you're ready to go home. So you're drinking, eating, moving. You have time to fill an app in about how life is going. We developed this application and put it on a cloud-based sharing platform. And the real, the move that made the big difference was to give patients access and their loved ones access to the app. So they could see the compliance tick over moments, and they could see if mum or dad or brother or sister was having everything done. And there was nowhere for the providers to hide, and there was nowhere for the awkward people to get away with not complying with enhanced recovery. Our overall compliance went back to greater than 95%. Patients drinking, eating, and moving after all forms of major complex surgery went back to the 90% levels we'd seen before. And 95% of patients used the patient-facing side of the app, irrespective of prejudices about older people and technology, etc. It didn't play out. We then had a national program which reconsidered enhanced recovery and reduced it right down to 5 major steps, of which I'm just showing 2 here, which is to optimize pain management and then focus on the dream. Have a goal of greater than 90% of patients nationally after all forms of surgery, drinking, eating, and moving within 24 hours. So to conclude, here is the latest results of our follow-up evaluation of what's happened more recently with regards to dreaming in the United Kingdom. It's from Matt Oliver and Ramani Munasinghe and the Perioperative Quality Improvement Collaborative in the United Kingdom. It's in press in the British Journal of Anaesthesia, so I can't show you all of the results, but I can share with you what was presented in abstract form at the Evidence-Based Perioperative Medicine meeting in London last year. So the objectives: to evaluate the association between drinking, eating, and mobilization within 24 hours of surgery and post-operative length of hospital stay, and the potential for dreaming to be adopted as a simplified alternative to more complicated enhanced recovery programs. Prospective cohort study. This is snapshots that are taken by the Perioperative Quality Improvement Group in the UK, very similar to NESQIP in the USA. So we're presenting here just over 22,000 consenting patients in 135 National Health Service hospitals in England and Wales. The exposure is elective non-cardiac surgery requiring at least 24 hours of hospital admission. And you'll see some of the detail, but basically it represents the big surgeries, dominated by colorectal, but also a considerable list of lung resections, liver resections, pancreatectomies, joint replacements, etc., etc. The variable of interest was dreaming, patients that achieved the drink, eat, move within 24 hours. The primary outcome was prolonged post-operative length of stay, defined as greater than 75th centile for the procedure. Secondary outcomes were post-operative length of stay, major complications, etc., etc. It's a very, very rich and detailed paper. I do encourage you to look out for it when you can read into all the different elements. We're just going to show you the headlines here now. So 22,000 plus patients in the main cohort. We're seeing here age, ASA status, for example, so the distribution one might anticipate. We're going to be discussing one major subgroup, which is the colorectal surgery subgroup. And within that, that's filtered down to be the 4 major colorectal surgery procedures, so the hemicolectomies and anterior resections. The multi-specialty subgroup for comparison, which I'm not going to go into the detail, is the other long list of common procedures, major procedures, of which there's more than 400 in the cohort overall in each section. So more than 400 lung resections, more than 400 liver resections, for example. What we're looking at here is the dreaming was associated with substantially reduced odds of prolonged length of stay. So you can see the odds ratio there is about 0.5. So that's a big reduction with a p-value of less than 0.001. So those of you who aren't familiar with odds ratios, that's a big result for it. Looking at it more pragmatically and simply, this is what was presented in the abstract. This is hospital length of stay, and in the UK, you can take that as to home. So we don't use the intermediary facilities, so this is a real length of stay to home. We've divided here the patients according to the dream rates by facility. So quintile 1 here represents the length of stay for the organisations that had low dream rates. Quintile 5 is the organisations that had high dream rates. So in quintile 1, you've got a 33%, so a third of patients only achieving drink, eat, move. At the other end of the spectrum, you've got 80+% of patients achieving drink, eat, move. Now, quartiles 2, 3, and 4 all do better than 1. 5 does much better. So there's an overall 2 days reduction in length of stay according to the hospitals that are achieving high dream rates. When you look at the fine print of the paper, there's no other explanations from the point of view of major morbidities or other things to rationalize. It's all about process and living the dream. So here are the proportions. Less than 33% at one end of the spectrum, 80 to 100% at the other end of the spectrum, a length of stay going from a median of 7 days with an interquartile range of 5 to 9 compared to 5 days with an interquartile range of 4 to 8. So in summary, drinking, eating and mobilizing within 24 hours of surgery is associated with a greater than 25% reduction in length of hospital stay. A small number of non-modifiable patient factors may influence whether or not a patient can dream, but actually it's a very small impact. It's not all about the patient, it's about the process. Structural factors which may act as barriers to dreaming should be evaluated, and when you look at the paper when it comes out, you'll see there's a lot of information there about the impact of tubes, drains, drips, choice of epidural versus different regional. So please do keep an eye out for that. So my conclusion is drink, eat, move after major surgery. Enhanced recovery is all about helping our patients live the dream. Thank you for listening.